most of you have made acquaintances with our American guests, but just for the sake of it, we can mention that you, Anna, you're from an academic emergency department in Atlanta, Georgia, right?
Correct.
Yeah. And Anjni, you work a bit further up on the east side of the US in North Carolina, in Durham.
Yep.
And you're a fairly big center as well, but you're not a trauma center, right? Or
We're a level 1 trauma center.
Yeah, you're a level 1 trauma center as well. Yeah, so sorry. And for our Swedish participants here, I think you probably all know where you work, but you can mention it anyway.
I'm at the university, also level 1 trauma center, academic hospital in Uppsala, just north of Stockholm.
Lina.
And I'm in a community hospital in the southern part of Sweden, Ystad.
Yeah, and I work in Linköping, which is also a university hospital. And so the focus of this last panel discussion is leadership in emergency medicine. And I mean, that's a very wide topic, and we've sort of together tried to analyze a bit of the topics that have come up over this week. And one of those topics I feel is the sort of taking control of the emergency department as emergency physicians, both taking the responsibility and also, in a sense, making it a given that it is us as emergency physicians who are responsible for running the emergency department in all respects. And I know, Lina, you have quite strong feelings about this. Would you like to elaborate a bit on your view on this?
Yeah, absolutely. Thank you. Sorry, it sounds really loud. I think that, I mean, we've come such a long way during these years in many places, but we still have a really long way to go. And I think that we have to look out for the stagnation. Because I think that the stagnation, if we don't continue to develop, we will lose emergency physicians to other specialties, because Swedish emergency physicians feel a little bit amputated. And I strongly believe that in places where we have seniors that have been pushing, like really bulldozing the path, and pushing and pushing, we have to give all kudos. But we also have to give a mandate to the younger specialists and the residents that are coming along. And it is up to the seniors to give that mandate. And it's important that you don't become that old surgeon that's like, we don't do this here. We've always put drains for pleural effusion via X-ray or whatever. So we need to give that mandate, and we need to let the residents know that they have the mandate and build the confidence. And if I can just give a really short story as an example for this, one of my residents came a couple of months ago having this mandatory identity crisis that you have in your occupation, saying, I don't know if I am where I'm supposed to be, I don't know if I'm learning what I'm supposed to learn, and he's really, really good. And I was like, calming and soothing and saying, yeah, you're absolutely, he looks at me and he goes, I don't even know if I have the opportunity to become what I should become. I mean, what is my role model? He said. And he looks at me and he goes, are you my role model? Is this it? And so I had 10 seconds of, and then I thought, no, absolutely not. I am not your role model. You are already better than I am, and you have to become even better. And then the next generation has to become better. And we have to let the residents know that. Then you teach me. You help me. And I think that's really important to start talking about, that we have a flat culture. And I guess that's...
So for you, y'all, the thing is, I've learned that saying you guys is not what we should go for these days. We should say y'all, because it's more inclusive, as it doesn't entail a certain gender. So that's suggestion now, moving forward. So but it's really interesting. I'll try to implement it. So for y'all working in a system that is well set up and well established in some respects, at least. How do you manage the possibly a sense of stagnation, or how do you keep up the momentum with continuous improvement? What's your take on this?
I think there's always challenges around the corner that you have to meet and then overcome. And there's always different areas of growth opportunity. So, for example, we are a level 1 trauma center. We've had an emergency medicine division under surgery for 20 plus years, and only 3 years ago did we come out from under surgery to become our own department of emergency medicine. And so that was something that we fought for many years. And since that time, we've had to overcome other challenges throughout our own institution. And I think it's really allowed our emergency medicine physicians within our practice to kind of come into their own and think creatively about other ways that we can interact with our colleagues within the hospital, other ways that we can innovate and do things that we weren't doing previously, and really kind of come into our own standing. But I think a lot of times people just assume that, oh, okay, we've made it, now we're done. We've made this past this next hurdle. But there's always new challenges and always new ideas to think about how you can innovate care for your patients and how you can innovate the treatment that you're providing to your patients, as well as just the structure. How can we creatively think about how our department is structured, how our emergency, how our relationships with our nurses, our techs, our other consultants in the hospital, how those relationships are structured. So there's so many different avenues that you can look at to continue to improve and iterate on what you're doing.
Yeah, I think that medicine in general is all about building on the previous generation. Like, we're not usually leeching people anymore, for example, right? So I think that in emergency medicine, we have a really great opportunity to innovate in an accelerated way because we are newer, and we are able to take that in a more rapid way. And I agree exactly with what you said, that every generation of emergency medicine physicians should be better than the previous generation because there's more technology and there's more knowledge, and that we should keep exponentially growing, and there's no reason not to do that.
And so I suppose a direct follow-up on that is, who then sets this agenda? Should it be the new generation setting that agenda for us as seniors, or do we do it together, or is it society demanding stuff from us that sets the agenda? I mean, this is an open question to all of you, so feel free to comment.
I think it's a bit of both. I mean, it's all of that, a little bit. Societal needs, the structure of healthcare, wherever we are, and then the new generation asking for things, but also the old generation is wise and should provide some guidance. So I think a bit of all of that together.
What's your feeling, Susanna? I mean, you're in the system where you were actually really early adopters in Uppsala for emergency medicine, and then you had a bit of a downturn for a while, and now you're really up and coming again really strongly. So you've sort of survived the dark years, and now you're back. And so what's your take on this? What do you how do you think we set this agenda moving ahead?
I think these kind of meetings and international meetings in emergency medicine, to meet your peers and discuss these things and move along and feel the collective strength from discussing with your peers and what's the next step, and also to be familiar somehow with some of the very well-known bumps in the road. What fights have they had, and how did they tackle that, and what can we prepare ourselves for? But also to make sure that we don't passively exclude our younger colleagues just because we are so used to, as seniors, pushing the barriers the whole time. So that to make sure to invite and show the opportunities, but also for the younger physicians to accept that invitation and to crave that invitation and put up a hand in different settings and say, I want to do this. Well, who can do that? Well, I'm here, and I think that is to feel the strength and not hide behind the sort of feeling that somebody else should have prepared something and fixed the infrastructure, because there's a lot of infrastructure needed and so much to be done, and we have just started.
Yeah. I mean, in some respects, we've only just started. On the other hand, I feel sometimes when sort of trying to look at this a bit from a more overreaching perspective on healthcare as a whole, that we also have a big advantage in that we don't have these fixed structures as yet. I mean, I know I'm married to an anesthetist, and I mean, the type of discussions that they have in their association around small things, changing just routines, which should be like a 5-minute discussion. I'm sure that would be like a 10-minute discussion in our association, could take like 2 years. So I mean, there is also an upside sometimes to actually being the new kids on the block, so to speak, and that is obviously I think also a window of opportunity that we could use. But how do you feel? Yeah.
I think that we as a community have to keep our eye on the target.
Yeah.
You know, the emergent patient, and what is best for the patient, and then we have to grow a thumb, and to grow a thumb, we have to grow the thumb to use the hand. All right. And we have a lot of people that have gone out on rotations abroad and learned a lot of skills that we might not do every day in the ED in Sweden. And we need to give the mandate, and they need to take this responsibility as well, to have this knowledge, but then teach it. Because we can't expect that everyone else, the anesthesiologists are not going to teach us airway. It's not going to happen. We're going to have to do this ourselves. And we need to use every single person and just take small steps, I think.
That actually segues into another topic which I feel has been recurring over the week, and that is how in a community where the academic experience is still fairly low, so that not many people have real training in teaching, and many people haven't even tried doing any teaching, and we don't really have that culture, at least not in all hospitals. It's very uneven. So how do we transition into a culture where actually teaching and bringing home knowledge and also dispersing the knowledge and just not keeping it to yourself, how that becomes a normal thing? How do we make that transition, do you think? It's also an open question. Any suggestions from you?
I think that there's a lot of teaching that happens that's not big T teaching, I guess, like on shift. I think there's a lot that our next generation is learning from us, and how you move your flow and move through the emergency department, and kind of like those nuanced skills. And I think we should feel comfortable in kind of like teaching those type of skills, because emergency medicine is sure pathophysiology and management and everything else, but it's also like a lot of the art of like being in a space. And I think we need to be better at calling that teaching, because I think trainees don't realize they're being taught when they're kind of in that space, and then also kind of owning that as part of our job.
I think that's a very important point, because, I mean, if you're training as an orthopedic surgeon and you're in the OR actually learning how to bang on an orthopedic nail or whatever, put in the screws and the plates, that's very obvious that you have a teaching situation. But in an emergency department where a lot of the sort of intangible skills are just making the logistics work, having a feeling for where to go first, and knowing that I might be able to leave this person more or less on their own because they'll manage, but this person needs a lot more support if we want things to run smoothly. And that is sort of implicit knowledge, which might not be obvious, especially if you're junior and you're not really used to the context. I think that's a really important point. What's your take on this?
I also think, just as you say, to call it teaching or to realize that what we are doing is teaching, because we are opportunity makers and we are opportunity takers, and to take the chance of a small micro teaching session can mean so much more than to listen to a 2-hour lecture. When you are at the patient and you show the way, and you, as a junior physician, then can feel the satisfaction of actually accomplishing whatever practical procedure, or then you have sort of gone through it with the support, and the confidence that that gives is really important, I think.
And also the other way around, as a senior physician, I think it's important to bring that up. And we can look at the procedural sedation that actually has started working in very many places. You need to find one person that knows this or learns this, and then, give them the mandate and say, good, make a protocol, make a plan, and teach us.
Yeah.
And supervise me. And then it spreads.
There's a saying in the U.S., see one, do one, teach one.
Yeah.
And I think that speaks volumes to what is possible, and also just going back to that question of ownership and kind of projecting that idea that this patient is yours. If a consultant comes to care for the patient, it's after you've requested them. So it's your patient otherwise, and a consultant shouldn't be treating that patient without your permission.
I feel in many ways now also in Sweden we are in a transition phase, and it's going to last for a while if we look at Sweden as a whole. And we have just drawn a map or a sketch of our new house, but not too many people see it as anything else than an air castle, ett luftslott in Sweden. I think also for us to sort of paste our emergency departments with the atmosphere of ownership. And I never want to hear a resident in emergency medicine saying that, oh, I'm the surgeon today. Like, I kill. No, you can't say that. And even worse when it's like, oh, I'm going to refer that to the ortho on call. When you are not a specialist in being a junior physician at the emergency department's corner, you are going to be a specialist in emergency medicine. I think that ownership and to have that and provide that backbone and support, to me, is essential.
You almost sounded like that American comedian Jeff Dunham when he screams, "I'll kill you." You know that? Have you seen that? You have to look it up, otherwise. It was really similar. You should try that with the residents if they don't listen to you.
They don't.
They don't? Okay.
The ones who did are dead already.
Okay.
But it's also all the, we're not or you're not allowed to do this in the emergency department. And that's also, no one can tell us what we can do or can't do. It's up to us and our competency. We shouldn't do stupid things, but,
You have a great benefit in being every physician being equally able to do any job here, where you don't have credentialing for what skills you can perform and things like that. So, I mean, you have a really big opportunity to just do it. And then maybe you get in trouble a couple times afterwards, but better to do it. And then sometimes when it works, then you've claimed that skill.
Yeah, I think that's so important. And that also transitions into, I think, one of the other topics that have been recurring, both in all informal discussions that we've had over the week and also with our panel here, that with this opportunity and the responsibility also comes the aspect of anxiety, or possibly the fear of doing ill to our patients, doing wrong, and the general sense is that most of us, I think, at this stage of our development, we have embraced the fact that if we want to have ownership for our specialty, we also have to live with the fact that we have to take full responsibility for the management that we do with our patients. It's not like we can call the orthopedic surgeon and blame them when something goes wrong, but on the occasions that things go well, we'll take the credit. That's not how it works. We'll take both the shame and the positive side of things, but that seems to elicit quite a lot of anxiety within many colleagues, both on junior and senior level. I don't know what you say. What's your
that also brings up the importance of having the skills that you need and creating that environment, building that house so it's visible for us, ourselves, and for others, that there is an infrastructure here, and to create a work environment where you can practice safely and be prepared to do the work you're supposed to do for any patient, for every patient, everywhere, anytime.
Good.
Right?
Yeah. And so I think now for the last bit here, we should definitely open up for questions also from the audience. And I mean, these things that we're saying now, they probably elicit quite a lot of different reactions, and some of us feel more comfortable with some aspects of this, but it would be really interesting to hear what some different takes on these topics that we've touched on. So just raise a hand. And it's really nice if you say where you work, just so we know.
My name is Omer. I work at Sahlgrenska. I just in the Swedish system, at least, I think that we have a ongoing identity crisis as emergency doctors. There's no consensus on what we actually are and what we're supposed to be doing. And I have my opinions on that, but I would like to hear what the panel thinks. What is the role of the emergency specialist for all of the emergency specialists? Is there any ways of having a consensus throughout all the different clinics?
And your question now, just to frame it, is it more of what our process would be to reach a consensus on this, or is it our take on what it should be?
Kind of both.
Okay. One of them is easier than the other, I say, but would you like to start?
Well, my spontaneous answer to the easier question is an emergency physician takes care of all emergent patients until they're stable.
Yeah.
Thrombolysis for stroke. Are we going to be doing that?
Yep.
Yep.
You should.
Yeah.
We already do it,
Yeah.
where I work, at least.
And depending on the setting, of course, we have to collaborate with our colleagues from other specialties, and of course, to work hard for the specialist-driven emergency departments where we collaborate with our specialized nurses in emergency medicine, so that it's not only us physicians, we're not omnipotent, you can't do it all, but you need to know when to ask, who to ask, what are the guidelines, and how can we support the flow and the throughput for the patients so that it's safe, effective, and of course, the best practice. So, yeah.
I think the role of I think the definition of an emergency physician is well defined, what you said. It's more, you don't have to define yourself by what everybody else thinks. So we are defined, that's our definition. We take care of anyone, any place, anytime, right? Until they're stabilized to the best of our abilities. Just because anesthesia and surgery and internal medicine don't see that or don't feel that, that doesn't change our definition. So it's more about how you implement that definition, how you kind of create your space.
And stand ground, I think.
Stand your ground.
Really stand ground when they come, like the specialist förening.
Specialist association.
Thank you. Specialist associations from other specialties that come and say, but our residents need to be in the ED with tutors from us. We need a infektionslinje. No. stand ground. They have an identity crisis too right now because it's rings on the water, right? Suddenly you wake up and you realize that I'm an infectious disease doctor and I might not be the best person to take care of the sepsis in the ED. And that's scary, and they'll get over it. We have to stand ground.
Yeah. Yeah, I think that's a really good point, and I think that's a quite common sentiment in our community that the ground that we've gained, we really have to stick on to that. And also, I think it's important how we communicate about this, because internal discussions like we're having now amongst colleagues, here we can be very open in that we're having this potential identity crisis, and we can have a lot of discussions about what is actually an emergency physician. But externally, when we communicate, it's probably not that productive if we focus on that aspect. Instead, we should focus on the things that we actually agree on, because in that way we create also a common notion amongst our colleagues about what an emergency physician is. And I think it's extremely important what several of you here say, that if we can't agree on anything else, then probably the basics, that we just take care of any patient coming to the emergency department who needs emergent help. And that's sort of a basics. Then we can go into the nitty-gritty and we can spend years and years defining small stuff. But as a general idea, I think that's excellent. Protests? Järhult?
Yes, big protest.
Yes, feel free. That's why we're here.
After 20, I think I started 2002 in Södersjukhuset. I'm tired to be too much trevlig.
Nice.
Too much nice to other specialties, because I really see their lack of knowledge in emergency medicine and even their lack of skills. And that's like above all specialties. I mean, I can tell you examples from every specialty where they do, like, let it be the gastric sonde the surgeons want for everybody in the tube. Like, no evidence for that. Worst procedure. It's worse than getting a catheter. And I'm tired of fighting and being nice. I think no surgeon is nice, no orthopedic surgeon is nice, no internal medicine is nice. They all think we are idiots. And we've been the idiots, like when I started. We've been like the Taliban of the hospital. I mean, it was, and we were like unexperienced. I was unexperienced. But I mean, now it's more than 20 years ago. So I'm not saying I'm taking conflicts actively, but I'm not the one begging anymore.
Not taking any more bullshit.
Yeah, that's the other way to put it. So yeah, I would like to protest.
And what's your biggest point then in protesting? I mean, what's the biggest thing that we should act on, you think? Because we need something concrete to actually act on.
Actually, the first thing we have to do is to convince our junior colleagues on that we don't have to listen to what anything else is telling us. I can feel that if, like, I'm very allergic to that. There's one Södertälje doctor here. I'm very allergic if a junior comes to me and tells me I consulted with a surgeon and they tell me to that and that and that. And I said, like, okay, call the surgeon back. You didn't consult me because that's useless. Yeah, but the surgeon said it. And number one, it's not a surgeon told them, it's like a first-year resident. And number two, the surgeon hasn't even seen the patient. And that's like, I think we have to, as the seniors, we have to be very clear on, and that costs a lot of energy, even for me, to lift my back, my buttock from my chair and go to the patient and together with my junior, examine the patient and say, now we do that and that and that. And then when we have it done it and decided, then we call the surgeon or the doctor having a sign on the chest that says surgeon, which is the difference. So I think a lot of these discussions have nothing to do with other specialties. It has to do with us as a specialty, as like a culture. I think we still have the problem that we look at other specialties as if they would be more competent in our area, which they are not. By nature, they are not. It doesn't mean that they are stupid. No. It just means that we are on our turf and they are on their turf, and we need to collaborate. But we need to change that culture of thinking.
Sure. No, but I mean, emergency physicians, big round of applause for you then, Järhult. But I mean, my feeling when going into emergency medicine was actually that a lot of other specialties had the idea that we were all slightly retarded, and the retarded people went into emergency medicine and the smart ones went somewhere else. And I think we all still live with some of that in different respects, but then could we do some kind of cultural indoctrination then? Maybe that should be part of our training.
I prefer Taliban.
You prefer
retarded.
Yeah, that can stand for you. But I mean, seriously, do we have any ideas of this? I mean, if then we, aside from having challenges in organization and partly in our knowledge base, if we then also have a cultural challenge, how do we actually address this cultural challenge?
Hello, I'm Angela. I'm from Segerstand. I think the culture change is when we take place in higher ups, in boards. We take place in to be instructors in courses that is in collaboration with other specialties. So they acknowledge us as a specialist physician in the same level as they are. So we have to be managers, bosses, higher ups to take place in the organization. Then we will have respect, because that's a specialist in emergency medicine that sits there and is a boss. So that's my take.
Yeah, I think you're very right there. What do you say about that?
Yeah, absolutely. Yeah, you have to get a seat at the table, like what we talked about a couple of days ago. But having leadership roles in hospitals, having leadership roles in multidisciplinary education and things like that, universities, that shows how competent an emergency physician is.
Something I've always thought about myself is that all of us have to take ownership for our own competency. You can't just wait like, oh, nobody has taught me this, nobody has taught me that. Like, all the information is out there. You just have to go look it up yourself and make sure, okay, now I know this, and then just act on it. There's like a lot of us who's been growing up the last 10 years has had to do this ourselves. And I mean, the next generation, maybe they don't have perfect role models yet, but they do have some role models, but they need to be better than us. And to be better than us, they need to know more than us. And then, I mean, I can't teach them what I don't know. So then they have to get that information themselves. And, you have to just realize that it's on you. It's not on everybody else to teach you.
I agree. So any other comments here? We have a few more minutes before we'll transition into the next block. Bakom dig, Jonas.
Hi, I'm Martin from PTO. It seems like what we hear is recurring identity crisis, and I think the way forward is also unification from us as emergency physicians. I've talked to some of you here, and it's like, oh, PTO, yeah, like, do you have emergency doctors? Like, yeah, there's like 10 of us. We're not many, but we're kind of isolated. And I think herein lies the strength. For instance, SWESEM as an organization, if we could have some kind of help reaching out to more, to bigger clinics, more like maybe a newsletter, like, oh, it was amazing what we heard from Sahlgrenska, how you managed to salvage a kidney. I have like no idea that was at all possible, and certainly not in our current states where we have 3 hours to nearest ECMO. But also some kind of where are we located in the country? How many of us are there? Which I understood from day one, like, okay, we know how many specialists, but how many residents are we? What numbers are we talking? And also that would perhaps give us some insight into perhaps I need to believe in myself more. Well, maybe I can do a small rotation in a small hospital where I'm allowed to do that. And in the opposite, oh, I have not so much experience in trauma. Maybe I could go to a bigger trauma center to get that experience. And I think this would be beneficial and also make us a more homogeneous group.
So having the association also as a platform for exchanging experiences and also making seen what is done in many places, but now in a more possibly isolated fashion, then I think Frida will take note of this because it's a good idea. And I mean, a lot of this, when trying to do this kind of thing, I think we as an association would benefit from having then stakeholders in your different sites who can actually provide us with some material. Because as you point out, for me being down in southern Sweden, and I've been in Piteå like twice in my entire life, it would be really difficult for me to write a news feature about how you guys are operating. Ah, shit, now I did it. Y'all operate up there. And I think then if you can just identify, a few of you in different locations where you feel a little bit left outside or unnoticed, and just let us know, I think we can arrange so that these things are featured and that you become more part of the discussion. Don't you think so, Frida? Yeah.
We have a social media group in the styrelse.
The board.
In the board. And one of the things we're trying to do is to make good examples from all around Sweden. We've done a few of these now. So if anybody has just a portrait of one person, what they've been doing that day, or anything that you think would be interesting for anybody else, since we just send it to us and we'll put it up. We try to have one of these a week. We had one from Sundsvall, doing a resident doing a procedural sedation, for example, and yeah. So just if you have something, just send it to us, and we'll put it up. A picture and just a few sentences is enough, just for inspiration, basically.
Is it on Instagram?
Yeah.
Yeah. So we send it on Instagram and you put it up.
All right, you can write us on Instagram. I think that maybe that's easier, and then we'll do it via mail, or just email me or Malin. But if you don't remember me, just send a message on Instagram, and then we'll just connect with email there.
Perfect.
Yeah, and just as a final note on that, on sort of the reaching out point, I'd say that just contact us by any means, and you don't have to feel you're the named representative of your emergency department or clinic or whatever. It's fine to be a single emergency physician feeling that we need some more attention to our emergency department, so you don't have to feel you have to be named as a representative or anything. Just reach out and we'll make some kind of feature. Yeah, I think it's about time that we start wrapping up, but are there any final thoughts from our panel?
I did have a final thought on this discussion. I think it's really key to highlight the successes as you've been discussing, not just internally within SWESEM or within your own group, but also maybe within your institution, and to gather more awareness of what emergency physicians are capable of and the competence of emergency physicians in managing some of these acute patients and conditions that might otherwise be, historically under the purview of anesthesia or whatever, but highlighting saves, cardiac arrest saves, that kind of information is really powerful, and I think it shows what we can do.
Absolutely. I was also thinking about the bumps. It's different in every institution what your main problem is, but I'm not actually a big fan of our reporting system, avvikelser, because I don't know how many you need for them to actually build a change. Is it 100, 100,000, 10? I don't know. But when things happen, like we were talking with my colleagues from Skövde, when you get a traumatic cardiac arrest, and the surgeon that's supposed to be the team leader is a year 1 resident urology. And that patient was so lucky that the emergency physicians was there and said, I'll take over. Okay? Then you need to write an avvikelse, because you might not have been there. And then that patient would have died. And that's a systematic flaw. And we need to open our doors and see that all these traditional things, we've been doing this for 100,000 years, so we'll continue. Maybe that's actually an avvikelse, because it's not the best care.
Yeah.
I would say also our biggest allies are probably the patients. We have to use them more, because they were there when we made a change. And to try to sort of meet up and share those sort of sunshine histories in comparison to the systematic reviews of all the fails that happen at the emergency department that we can't necessarily take charge of or be guilty of. We can start to clean up our own house in some way, but to do that we need to visualize and sort of shake hands and collaborate with the patients, because we're not doing that enough. They will speak for us.
My final advice is just do it. Don't ask for permission, just do it. And no one is going to give you the permission or the stamp of approval until you just go ahead and do it.
So thank you very much.